Hello, thanks for joining the second edition of Education Exchange in our partnership with the Society of Diagnostic Medical Sonographers and GE HealthCare. My name is Beth Barry. I am an educator with GE HealthCare and am very excited for today's guest. Today's topic is pediatric ultrasound and the pediatric ultrasound practices of today. Joining us from Texas Children's, the Section Chief of Ultrasound, Dr. Nadia Mahmood. I candidly huge fan. I think you know that. And I just such a passion for the field, such a passion and advocacy for ultrasound and pediatrics and where it's come from and where it's going to. So I'll turn it over to you and introduce yourself, Dr. Mahmood.
Well, thank you. First of all, thank you for inviting me. I think this was such an honor to be invited. And Beth, I feel the same for you. I think we see each other at conferences or wherever we are online. We always have a great time and have wonderful chats. As you said, I'm Dr. Nadia Mahmood. I have been at Texas Children's for 15 years, showing my age a little bit, but I did my fellowship there, so I was trained there, and I have not left. So I'm a Canadian import into Texas, but have always loved it there. And I think I'm very grateful to have been given the position of Section Chief of Ultrasound and that was in 2016, because of what I've learned and due to a passion, as you know, from childhood. And maybe we can talk a little bit about my path into pediatric radiology and why I have such a passion for pediatric radiology and ultrasound in general. But apart from that, as you know, I was also the chair of the pediatric community. First, you start as secretary, then vice chair of chair. So I was involved for 6 years at the AIUM, which I think really then fortified or strengthened my position and my passion, and was able to be more of a voice for pediatric ultrasound, on a national and international stage. Since I left that chair position, I was nominated to the Board of Governors, and that's a 3-year term. So I'm currently serving in my second term at the AIUM. Yeah, it's a little bit about myself.
Love it. Thanks for joining today. You alluded a little bit, and I think that is where a lot of our strong connection came through is, I worked pediatrics for a while. I've had some kiddos that have gone through the gamut of pediatric care, all healthy now and great. But, talk a little bit about your background and what drew you to pediatric ultrasound.
Well, for those of you who may know, and you know my story, so at 15 years old, I was diagnosed with Hodgkin's lymphoma. So I spent a lot of my child as a patient in children's hospitals in Canada. So at the time, things were treated very differently. You were given a lot of chemotherapy, a lot of radiation, but the first test, even back then, was just a simple ultrasound. And I just remember from my experiences going through ultrasound, having CTs, having MRIs, you start to develop a sense of what was scary at the time and what's scary for children. I think I tell everyone this. I remember every nurse. I remember every doctor. I remember every poke. I remember who was nice to me. I remember who wasn't so nice to me. I was in a little town of 13,000 in northern Canada, and my parents were both physicians in this little town, and my dad was one of two surgeons, and one nurse actually said to me, "Don't think you'll be treated any better because of who your dad is." And as a 14, 15-year-old being told you have cancer and somebody telling that, it's pretty scary.
Yeah.
So I think I approached my life and my job with that perspective of, I have to think about the children. I have to think about how they feel when they're lying in that bed or in that hospital room. And then, like yourself, being a mother of two girls, your perspective of life changes a lot. Yeah. So obviously early on, not just because of seeing my parents in the field, it was more my own personal experience with cancer than having to deal with the radiation effects. I had kind of 1.5 to 2 secondary cancers about 20 years later in life in my 30s, due to the radiation effects of treatment as a teen. So I am an advocate even now at Texas Children's for screening of not just MRI, but even ultrasounds of the thyroid gland, especially because we know that children who have had irradiation to the head or neck have an increased risk of thyroid cancer later in life. They have an increased risk of leukemia later in life, and even breast lesions. And again, we could talk a little bit more about how ultrasound is really helpful in diagnosing all of those cancers.
Yeah, I think, you hit on a couple points. In my 1.5 years in peds and not that I exited the field that quickly, but going into general, it was always my favorite thing to say no pokes. No, I am not here to poke you. And I think as sonographers, we're very well aware of the non-ionizing radiation
Yes.
tagline, for lack of better words, but there's so much more to that. Outside of contrast, we aren't poking these kiddos. It's not a loud, clunky, scary machine. It's not a closed in area. We really do have the ability to be more favorable, less scary, and have a better, memory and outcome for these kiddos. To where when they come back, they're not screaming. It's not a traumatic experience in a lot of instances. And that was one thing that I always appreciated my patients walking away from, is not walking away in a way that, I was the bad guy or that I was the scary one. But I think the other thing you touched on is, back in the 80s, back in the 90s, I won't say what year I scanned pediatric ultrasound. But even back then, and my tenure wasn't that long ago, the mentality was still, well, we'll do a CT. And, where I look at it today, and when we have interns that come in and they ask, what do we use ultrasound for? My tagline is always, there's nothing we won't scan.
Yeah.
So let's talk a little bit about kind of how ultrasound's evolved. What are we all using it for now in peds? And what has been some of that evolution? What does that evolution looked like for you on the inside of it? Saying 15 years, things change hourly.
Huge advances in the last 15 years. And actually, when you brought this idea of talking about pediatric ultrasound, and I was like, I wonder, and then you start thinking about it, whether you'd be on a drive or whether you'd be kind of here and there. And I was like, when I first started as a fellow, we did a fair amount of ultrasound, but it was for the basics, right? Yeah. It was to diagnose appendicitis, which was the main thing. And what I wanted to scan and what I really wanted to find was the appy. And I'm really proud to say that the sonographers at Texas Children's, I think, from attendings who come from other institutions, residents, we have 4 or 5 different hospitals. We have about 140 trainees that train with us every year, plus our own fellows. We have a group of 5 to 7. They all say like, wow, these sonographers are amazing. And of course, in part, your machines are phenomenal, but it's also, we do so much of pediatric ultrasound looking for the appendix. So the appendix is the bread and butter of pediatric radiology, because most of the adults, even if you go to some of our adult hospitals and a kid comes in, they go straight to CT, because a lot of the times the sonographers, it is a lot of it is sonographer dependent, as you know, right? It's technical skills. So you need a lot of good practice. They go straight to CT. Why do we want to radiate children? And MRI, I understand a lot of people are doing MRI, but I don't like it because sedation, it takes longer. Again, why put them in this confined donut when we can just do an ultrasound? So back in the day, pyloric stenosis, of course, do it all the time. Yep. Appendix and intussusception, I think, were our 3 big things. Of course, right upper quadrants looking for livers and gallstones and things like that, right? But with the advent, and you and I have discussed this in a lot of discussions with GE, because we needed these packages. Look what we're doing with necrotizing enterocolitis. And I think bowel ultrasound has been extremely life-changing in a sense. In 2017, 2018 is when we started discussing this at the SPR. I love bowel ultrasound in the sense I'm kind of a bit of an advocate of it, is because you can detect necrotizing enterocolitis. You can detect indirect signs of pneumoperitoneum and bowel wall thickening, and you can see these beautiful bubbles in the bowel wall or portal venous gas before we can see this radiographically, right? So I always say to my residents, why should we wait for the bowel gas pattern on an abdominal radiograph to change, or wait for them to perf and to see the free air, when we could just do an ultrasound and we can look for complex free fluid? And then I can alert the surgeons, hey, I see complex free fluid. This child may have perforated. You may have to go to the OR. So I'm a huge advocate, or we are a huge advocate at Texas Children's and now in the pediatric realm, of doing bowel ultrasound to detect NEC earlier. Number 2, we do bowel wall. We have 2 ultrasounds at TCH. We have one for, like, it's called acute neonatal abdomen. Sometimes neonates come in with bilious vomiting, and you're like, is this due to a midgut volvulus? Is this due to NEC? Is this what kind of obstruction? So As you know, Dr. Haitwi Wen, she was one of my colleagues. She was actually my resident as well. She did her fellowship somewhere else, came back and worked with us at Texas Children's, and she was the one who implemented the protocol for midgut volvulus. So I think we were the first hospital to now diagnose midgut volvulus on ultrasound, because say I live in Sugar Land, Texas, and for me to drive to the Woodlands to do an upper GI in the middle of the night was about 60 miles.
Yeah.
We're like, how can we do this in a safe manner instead of them waiting for me to get there? And we're like, ultrasound was perfect. So with ultrasound, you can, again, a great sonographer, we train all sonographers, we do train them at all of our different sites. We spend a lot of time is looking for the SMA, SMV orientation, looking for that oral pull sign. And now our surgeons, after we publish so many data and papers, they kind of trust us. At first, we did the ultrasound and did the upper GI in the early stages to kind of coordinate the results. And then once they saw that, you know what, these guys are doing a pretty good job in ultrasound, we're going to trust it. So we don't even do the upper GI. We're saving radiation and we're saving us driving in the middle of the night, which is a secondary thing, but it has been huge. And the second bowel ultrasound we do is, of course, in our leukemic kids or immunocompromised kids, right? You're looking for typhlitis, you're looking for any infectious or inflammatory colitis. So I think in all of these kids used to get unnecessary CT abdomens and pelvises and repeat KUBs. And I think ultrasound in the bowel realm has been phenomenal and a huge, huge change. That's one example.
No, I think it's a great example. Candidly, again, I won't disclose what year, and if anyone's watching and knows, please don't share. But you nailed it. I worked in a pediatric hospital, and even in the pediatric hospital, we did appies, we did pyloric, and I think I saw one intussusception. And I'll be honest, when I saw that intussusception, I was like, I've seen it once in a book, because the doctor was like, are you confident? I've seen it once in a book. I'll leave it there.
Yeah.
But you could see the layers of the bowel, but beyond that, we didn't really dive in. And yes, technology, thank you for that credit, but yes, technology has brought us there, but also the willingness of physicians like you to spend the time, because a radiograph result isn't the same result we're going to get on ultrasound. And to spend the time to dissect those out and to document those and to share that knowledge has really changed. I would say bowel ultrasound is one of the biggest, advances in pediatric, number one, diagnostics, and number two, radiation. We don't think of a KUB as being that much radiation, but any is more than none.
Yeah, and when you do them every 6 hours and you do serial KUBs for days on days, looking for those like portal venous gas or pneumatosis, pneumoperitoneum, all again, of which can be seen sonographically. Is it difficult? Yes, I do think sometimes pneumatosis can be difficult, but at least, we're going to see the hyperemia or the abnormal loops of bowel. The biggest thing that I love is turning on the cine and looking at the hypoperistalsis, right? You see these thinned bowel walls and they're just not moving and they're sluggish. I can't see that on a KUB. I don't know what's going on. So that real-time motion, and I always make sure that the cine clips are given to me of all four quadrants, I think is really important. And we always kind of try to train the trainees in looking at that. It's not just looking for hyperemia and bowel wall thickening and free fluid and complex fluid. It's also looking at the motion. Are these loops of bowel moving? And then incidentally, you find so many other things, right? When you're looking at ultrasound. So, I mean, I can talk about ultrasound all day, but we still do it, right? We still do pylorisis, we still do appies, and we do a lot of intussusceptional ultrasound. Those are definitely not going away. I think thyroid, we've always done a really good job in thyroid ultrasound, but I think we do more breast ultrasound now. Because I am a huge advocate of not giving it to the adults. I think the knee-jerk reaction in the beginning was there's 15, 16, no, we don't want to touch it. It has to go to breast center. But what we found, and written a chapter on this, is the adult folks don't understand necessarily the developmental kind of process of the developing budding breast. And due to that, they may not recognize normals and normal variants, and they may misinterpret them as masses when they could be just dilated ducts or just kids get fibrocystic disease, and they don't realize that. And thank goodness the majority of breast lesions in children are benign, like 90%, 99%. It's very rare to have breast cancer. Have we seen them? Yes. They're mostly metastases from other organs and other type of cancers, because unfortunately we see so many at Texas Children's. But I think the best part of what I love to do, especially when I'm more in the community hospitals, we have the West Campus in Katy and the Woodlands. I love to go into the room and just give the parents, not just on breast ultrasound, any lump or bump. You give them right away a fast, easy answer, benign, malignant, follow-up or not, go have a good weekend. And I think being a parent like you are, the biggest thing we can do is give them that peace of mind. And give them an answer right there. I mean, I'm still waiting as an adult on a thyroid ultrasound like on Monday. Like, where's the results? But in pediatrics, I don't want the parents to wait. I don't want them to be stressed out all weekend. And I don't want to tell them like you have a big neuroblastoma on a Friday right before Christmas, which has happened many times. But I do want to say, we do see something there. You're in the best institution. We treat these all the time. So at least we can have some kind of a conversation at the bedside. And then I'll let the clinicians kind of take over from there.
Yeah. Yeah, I think, patient care in peds, for those of us sonographers that do peds, for the physicians that work peds, you're working on multiple patients. Your patient plus your, the parents, and, even being a quote unquote medical mama, I still want to be talked to. Like, I know what you're saying, but I still want to be talked to like a parent. I still have the anxiety of a parent. And you mentioned kind of the more rural areas. I grew up in Nebraska, so these patients, these parents are driving 3, 4, 5, 6 hours, and even out here in Colorado, the same, to go to the children's hospital. They were told something locally, something didn't look right. They got a referral in. They've spent this time, they've made this drive, and whatever I can do, whatever we can do to lower that, or adjust that anxiety prior to them leaving, or to put them on the right path as soon as possible. I think there really is the benefit of ultrasound. I don't have to wait. I know my answer when that probe is on that patient, and I think that's huge. I think that's huge in pediatrics.
I think it is. And I've had a couple of my residents say to me, or even my colleagues, like, why do you go in the room so much?
Mm-hmm.
And it's that childhood thing. It's that feeling of lying there in a room and nobody talking to me or nobody talking to my parents. And I just want to be able to give them, just like you said, relieve a little bit of anxiety. This world is so hard as it is. There's so much suffering and sadness. If we can just be kind for 5 minutes and just make somebody feel better. I think it's tougher, unfortunately. I don't speak fluent Spanish. I grew up speaking French in Canada. But having, thank goodness, like great interpreter skills or great interpretation at Texas Children's, even though we can't communicate directly, if I have the interpreter there, at least you're sitting together. And I always, like you said, CTMR, I can't even go into the room with the patient, right?
Yeah.
And I just hated that feeling. I still hate that feeling of feeling claustrophobic. And I remember that CAT scan, deciding if I'm going to need chemotherapy or not. I literally remember the day. I remember where my dad was sitting. I remember every moment of that day. And I remember, just being alone in that cold room and speaking to someone on a mic. With ultrasound, we have the lights down and it's usually a warmer environment. And, Texas Children's, we have these beautiful murals on the wall. And then I sit on the bed. You're talking to the child. I may be scanning a bit. I may do my scan first, but then when you discuss with a parent, I think it's important to sit with the child or be at the same level as the parent and kind of speak, which is difficult to do with a CT or MRI. And I know we'll probably talk about this a little bit later, which is why I really wanted to move away from a fluoroscopic suite doing VCUGs that felt so sterile to me and OR-like, with these big lights and cameras, to doing contrast enhanced ultrasound, right?
Yeah.
Again, the lights are low, you're in a small room, the environment is so different, and the environment makes a lot of difference for kids. How many times do you see child life coming into an ultrasound? We don't need child life. A, our sonographers are phenomenal. B, it's not as scary. So child life is, you need that more for the CT, MRIs, VCGs, fluoroscopic studies. So I think that's huge, and that's a huge testament to where our field is going.
Yeah. And just the perception of kids too, right? You walk in the x-ray room and everyone lets up. And those 8-year-olds are not naive to think like, why don't I get one? Like, and it's a cold, hard bed, and there, to your point, like there's this big, heavy machinery, it's loud, all of these things. And so the ability to lay candidly on a soft bed with your mom right next to you, you know, minor interaction, quote unquote, with that patient, physically, I think it's just a more comforting environment for that patient.
Yeah, and we even have the screens. I'm sure you've seen that, right? Like the TV screen, so they can be watching a show or cartoon while getting their ultrasound. You can't do that necessarily. Fine with the CTMR, we do the goggles and all that, but it's still a much longer exam.
Yeah.
How often do we sedate for ultrasounds? You just
Right.
sedation and what we've been seeing and what the studies have shown, what sedation can do to, especially to our really, really young children. If
Yeah.
we avoid that, I mean, let's start with an ultrasound. Why not? It's the best tool to start with. And I think just with our volumes, what the dramatic increase in volumes I've seen in ultrasound, like to read 40, 50 just on a normal shift, that's just me. My colleagues are also reading the same amount, is showing what the ER is ordering. And I do believe, and I hate to say it, and they probably don't like me saying, but I really do think it's a new stethoscope. I don't think, because there's nothing wrong with this, but just the way medicine is going, physicians aren't seeing the patients in triage as much, right? It's the nurse practitioners and APPs, and they're wonderful. But sometimes they haven't even really seen the patient, but they just get an ultrasound.
Yeah.
That is difficult for me sometime when I call and I need more of a clinical history to say, am I going to go for like what, nappy or maybe borderline appendicitis? But oh, we haven't seen the patient. Well, why did you order the ultrasound? Well, they have right lower quadrant pain, but it's really replacing the physical exam, which can be good in some instances, but I don't want it to be overutilized in other, because the quality decreases and we still need to keep our quality high.
Yeah. It's that balance between fast tracking patients through, we understand that the patient to physician ratio, and the physician to really all care providers. We're short nurses, we're short everyone. But, is fast tracking, I've been called in for multiple right upper quadrants when the patient doesn't have a gallbladder. And, there are still things that can go on, and I understand that, but it's like that there's that drop in, communication, and there's that drop in fact finding. And it happens with peds too. Like, what is your pain? Like rather than just saying pain, and what a physician or what a child shares with a physician in an ER room when they're hooked up to an IV and they're hooked up to a blood pressure cuff. And, candidly, when we get to the teens and what is shared with mom within the room and what's not shared with mom when mom's out the room, having that conversation while you're scanning, for me, there was nothing more valuable than saying, like, does this hurt? Tell me a little bit more about your pain. Tell me a little bit more about your life. And inevitably, they're more at ease, they're more comfortable, but also I get answers I didn't have going into that exam.
We get better information from our sonographer sometimes in ER notes, right?
Yeah.
The majority of the time, I will rely on you all to say what was going on while you were scanning. When you pressed hard, did they scream there? You know what I mean? So you're right. I think the conversation you're having may be different than what I'm getting from the ER. Sometimes it's a combination of both, listening to you, reading your notes, reading their notes, having a discussion with my sonographer. But I routinely call you guys a lot because I want to know, are they jumping around? It's probably not happy if they're jumping around and eating a hamburger, right? So I think it's important to have that. I think one thing we may have lost a little bit in COVID was we used to have our sonographers come in and present every single case to the radiologist. And at that time, the volumes were less, so we could kind of do that. And we have these little teaching sessions. But now with this exponential increase in volumes over the last 4 or 5 years, we don't do that as often. I'm a big advocate for complex cases. We do a lot of screening. We do a lot of examinations for biliary atresia. We have some really great physicians. Our GI folks are, and our IR folks. So they're really big in the field. So those cases can be very complex if their status post a slide procedure and we're looking for indirect signs of portal hypertension, things like that. That's not something you can just write me a couple notes on. We need to have a really big discussion about this. We need to talk about the patient. So many of our kids are post-transplant liver kids, and those are the ones I want my trainees to be involved in. And then the trainee sonographers, because of, we built a new hospital in Austin and we have all these huge locations. We're constantly training new sonographers. So it's important not only for my residents and fellows to be in the room and to be a part of these discussions and to go in and watch the scan or to go in and scan, but I really want the sonographers who are training, they need to know the clinical side of it, and they need to know what I'm looking for or what I want from you all. So it's such an important, kind of like a synergetic relationship there.
It is. In the last education exchange that we did, we spoke with Dr. Allison Zupan, who is a dedicated breast radiologist out of Kansas City. And part of her and I's conversation was around, there's nothing wrong with a general radiologist, right? But a general radiologist doesn't see breast every single day. And I feel very strongly about that in peds too. And you alluded to it when you were talking breast and development changes in adolescent and even pediatric breast. But it's really the whole child. You literally start with this clump of cells, and in 18 years, you go from a clump of cells to a grown adult. And I'm not saying that there are independent challenges in adulthood, but there's so much of symptomology and diagnostics tied into development and into different development areas. Can you walk us through how when you bring in a trainee or a sonographer who's never dealt with this realm, this area of care, how do you have those conversations about, the developmental stages and the influence upon even what we're looking at in some cases?
I think it's really important. I think it's very cliche. And you hear radiologists or pediatric radiologists say this all the time, but we're not just little adults. Pediatric patients are not little adults. It's completely different. Can you sometimes see the anatomy more beautiful because they're thinner, right? There's less fat, penetration, all of that. But I do sit there whenever they ask me, I try my best to explain to them, we have so many children with underlying genetic disorders. So I think it's important to explain to them, I'm not going into details about the chromosomal abnormalities, but I can tell them that, say, facial features, or say if it's a kid with tuberous sclerosis, right? We have a lot of these kids. I have to tell them that we're not just worried about the kidneys. You may be looking at the kidneys, but these children developmentally, they get brain lesions, they get heart lesions, they can get liver lesions. So it's kind of the whole big picture in pediatrics. We can't just look at a renal ultrasound and look at the kidneys and say, that's fine. I think it's important for us to teach them. And I usually bring up on the PACS, you can bring up the timeline. You'll bring up the CT head. I'll show them maybe we did a SPECT looking for seizure foci. So you have to show them all of the scans, like of different modalities, not just ultrasound, in order to explain to them kind of how this progressed. So if you start from their brain MRI when they're a baby, or maybe they had a skeletal survey as a baby, you can kind of show them how they've been growing and changing with time. And I think just the multimodality approach is where we are going in the future. And I know this is kind of a bit off topic, but the reason I'm big on this is because I also do nuclear medicine, and a lot of PET scan. And I think there is going to be a future role of like fusion of, we already do PET CT and we already do PET MRI, but maybe for biopsy, maybe IR, because they do so many interventional techniques and giving, chemotherapy to liver tumors and things like that. We may be fusing PET with ultrasound in the future. So kind of helping our clinicians or helping the IR folks do biopsies real time. They already use ultrasound all the time, right? For FNAs and biopsies all over the body. But sometimes if you're looking for metabolically active tumors, I think that is something in the future we could look at. So it's not just explained to them embryologically, it's also showing them the different modalities that's involved, because I don't want them to just think it's just ultrasound. If you show them everything, I think it really gives them a good picture of what's going on. And you alluded to a really important thing is when I was 18, you kind of get stuck of where do I go now, right? My cancer is cured, but I'm always been a pediatric patient. So I went across the street. I went to MD Anderson. MD Anderson, great institution, one of the best in the world. But they really didn't know what to do with me, in the sense that they're never they didn't order a thyroid ultrasound or they didn't order a breast MR, and that's fine. They did their other follow-ups and everything else, kind of what they do. And then someone suggested to me that, do you know that Texas Children's has a long-term survivor clinic? And
Mhm.
that and I think that's really important as children like myself who've had cancer in the past, who need screening thyroid ultrasound, who need maybe breast ultrasound, who need breast MRI, you need a place for those children to go later in life because ultrasound is really important in those if we feel we're kind of told at 15, 16, you will get thyroid or breast cancer 20 years later because of the amount of radiation we gave you. So I would go into the room when I felt my thyroid was getting big and I scanned myself. And that's why I found these things. So ultrasound is not just for pediatrics and adults, it also helps in the transition phase, and that's why there's a whole field of transitional medicine. I mean, that's just a whole separate podcast.
No, I think that's a fair point. My sister-in-law's little sister is a CDH baby, and she reherniated when she was like 21, and the adult doctors were like, I don't know what I don't know what to do with you. And so thankfully her pediatric surgeon took her back on and repaired her, but it is such an important, I don't know that they're intimate to the case study because a lot of these kiddos, it's not a singular issue. We reverse a pyloric stenosis, we inflate a pyloric stenosis, we take a nappy, let's take out a nappy, that's fine. But a lot of these kiddos and children's are incredibly complex cases.
Yeah.
And then to try to turn over I mean, even my daughter, to try to switch doctors, I'm like,
Yeah.
schedule 2 hours, let's talk about it. Um, but I just think that they just don't have that experience. And it's not a negative towards those physicians. They definitely have their practice specialty areas, but to be handed this excessively complex case
Yeah.
and to look through all of the stages, that's got to be daunting, as a physician.
As a physician, but you know what the good thing is, and I think you use CDH because we do so much congenital heart disease.
Mhm.
I heard recently, and we have the adult, I don't know if you know that, we have the whole adult hospital, Texas
Yeah.
Children's Billion for Women. So now they take these children, say you had your congenital heart disease repaired at 5, 6, and you're followed with us. Now you're followed. So we're doing ultrasounds. Thank God we have an adult section, but I will read a 51-year-old right upper quadrant ultrasound. If it has nothing to do with their heart disease,
Yeah.
we still read them on calls. Like I'm on call tomorrow. I'm going to be doing the adult stuff unless there's something that's a little bit too complex and I'll, phone
Yeah.
up my adult colleagues. We're following these prior children with congenital heart disease or any kind of liver disease into adulthood now. And we're actually helping some of these women or young girls get pregnant.
Yeah.
They go to the pavilion now and we follow them through their pregnancy, which I thought was really amazing. Because again, some of the adults are not going to know how to handle these pregnant females with all these comorbidities and problems, right? Like I was very grateful that what I had was cured and done and you kind of move on. But some people have these problems that just
Linger.
you understand you're always in the hospital. So I think
Mhm.
that's really important. And then touching on that is kind of takes me to the other thing that I wanted to say that I think is a huge advancement is we have so many kids who have tetralogy of Fallot, right? One of the congenital heart disease. They're treated with something called a Fontan procedure, but a lot of them get Fontan associated liver disease. And so the big push and why we started doing elastography, thanks to your guys' package, was looking for indirect signs of hepatocellular disease. So I think we are very big on elastography at Texas Children's just because of our huge congenital heart disease population. How about all the kids with VOD? And we have so many kids with, unfortunately, leukemia and lymphoma. So elastography, I think, has been really great. I have spoken to a little bit some of my colleagues at CHOP who are now thinking of doing more elastography. They do it for thyroid lesions, and we're probably going to be doing it for breast lesions. So I think elastography is something I didn't do 15 years ago. And when you ask that question, then I had to make a whole lecture on it because my boss said to me in 2015, you need to make a lecture and teach everyone about elastography. So I think that's also been really helpful for us in the congenital heart disease realm to help our clinicians a lot.
Yeah, that was actually my first ever exposure to elastography. It
Really?
was in peds, and it was a study on our heart kiddos, and all of it was brand new. And even candidly, naively, right out of ultrasound school, in my mind, I had to re-educate myself of, okay, they're a heart kiddo. Why are we looking at the liver? And, we see those associations in adults too, but in kids, they're so delicate and they're ever evolving and they're ever developing. And, effects of one can massively affect, organogenesis of organic development of other areas of that kiddo.
And they started, like when the GI folks came and they started that, and then they approached us a few years ago and said, can we do splenic elastography? Mm-hmm. And the great thing is we're like, sure. So then you start these multi-institutional trials because first we're using all the adult normals for elastography, but then, right. A lot of great papers out of Cincinnati, and they started, now we have, and it's vendor specific, right? So we're going to use the norms that are related to GE because that's what we use. And now we have pediatric data that we put into our template. Mm-hmm. But so we have been doing it for a few years now. We do splenic elastography. Is that an indirect sign? Is that an early predictor of portal hypertension? So there's so many things that are constantly evolving. And I love the fact that we can talk to our colleagues because the Society of Pediatric Radiology, or even the AIUM, the pediatric portion is so small and it's very intimate. You've seen us at meetings. We're a very close group. And, we have this, it sounds cliche, but we really have a mission to improve pediatric ultrasound, radio, anything that to decrease radiation and to help us improve diagnostic accuracy, in children. And I think that's why I love our field is we all work together so well. We lecture at each institutions, we ask each other for help. There's not this huge competition that may be seen a little bit more in the adult world. It's much more cordial.
Yeah. I was sad to miss it this year. I got told I couldn't go to Hawaii. Big shocker.
Time with Colleen.
I know. I lost that battle. But no, I think that's such a, when we talk accuracy, and again, going back to, our last podcast, but we discussed how intimidating it is to be a general sonographer and, to see an adult and then, to do a liver and then to do breast and then to do a lower extremity. But then you add this kiddo, to the mix, and it can be daunting for sonographers. And especially again, it's a whole new subset of, what you're looking for. You're looking for Wilms, you're looking for all of these kind of more childhood specific things. And it's so rapidly advancing that it does get a bit intimidating. Again, I've been on the corporate side now that if I had to walk back into a pediatric department, I'd have to do quite a bit of studying personally. The ultrasound aspect of it never changes and the patient care never changes, but what we can do on both ends of that has truly advanced. And I'd like to go back to what you said about breast. Yeah. One of the things we've been hearing is, and candidly, I've been noticing, in my later third decade of life, I'm going to cling to that third decade of life for now. My time's wearing out. Yeah. But I see more and more women my age and younger that are getting diagnosed with breast cancer. And to your point, when I was peds, I don't know that I scanned a ped breast. I don't know that it came through. So are you seeing more of these cases?
I don't see more cancer. I think I'm seeing more masses, and thank goodness the majority are fibroadenomas.
Yeah.
I think because our cutoff is probably around 18, 19, the cancers that usually do occur in the 20s, and unfortunately 20s, 30s, which are more aggressive, we probably aren't seeing them. And if we do see something that's very aggressive looking, in that case, I am going to send them to a dedicated breast imaging center. Right? You just have to be safe in those situations. I think a lot of it obviously could be environmental. I think it's genetics. Today I heard on the radio that there was a bunch of plastic in our cars when we're like sitting in our car in traffic. Like there's just so much what we eat and what, you know what I mean? You understand all that environmental, because I get asked this question all the time. Why is there so much cancer now? So I do believe, yes, we're seeing more aggressive colon cancers, breast cancers. In pediatrics, thank goodness, maybe every few years I'll see something that looks malignant. Again, usually it's a metastasis from somewhere else. We can get like a chest wall, even sarcoma or an osteosarcoma or something kind of locally invasive aggressive, but I'm not seeing a lot of de novo cancers in pediatrics. But there's been occasional lymphomas and leukemias involving the breast. But if I do see a very large fibroadenoma with suspicious features, maybe greater than 5 or 6 centimeters, that goes into the giant fibroadenoma category, then I do send them to our breast surgeon. And it's up to them if they feel comfortable taking out or if they want to send it on. But thank God, I think at Texas Children's, because of our cutoff 18-19, we're not seeing as many malignancies as maybe Baylor nearby or St. Luke's,
Yeah.
thank goodness. But the secondary cancers is what we see, right? So this whole thing of me being their advocate is, they interviewed me for a newsletter because a lot of the girls who are maybe in their 20s now, if they had radiation, chest radiation at 15, 16, I developed very early breast cancer at 36, 35, 36. So almost 20 years, which is the latency period after my treatment was done.
Yeah.
And my youngest was 3 years old and I had to have like a double mastectomy. And these girls now we're finding are like, our cancer's done, we don't want anything else. So there's been a big push at Texas Children's to say, can you please implement or can we push screening in these girls more? And that's not ultrasound necessarily. Ultrasound is not good to screen dense breasts. You and I know that, but MRI is important. But if they feel a thyroid nodule and any head or neck irradiations in the past, right? So many kids with the brain tumors used to get whole body Wilms or irradiation. Those kids, we do start with ultrasound, and we have great ultrasound nodal mapping now. So, we have big thyroid tumor boards. So I think ultrasound is kind of our mainstay with thyroid imaging post-radiation, but it's really important to still screen these young women with breast cancer.
So we talk a little bit about, there's different cutoffs and there's different standards. You alluded to this with elastography. My question is, and this just popped into my brain when we were talking about breast, do you use the same BI-RADS scale or is there an independent BI-RADS with peds?
Great question. So we do not use BI-RADS in peds. And I'm actually not even using TI-RADS in thyroid. We use lexicon. We use our descriptors and everything, but we're not giving it a TI-RADS. Maybe some pediatric institutions are. So it's funny you said that because I had a resident about a year ago and he wanted to go into breast imaging and we got the surgeons involved and we kind of started this whole 4 categories of a BI-RADS for children. And then he graduated and it never really went anywhere after that, unfortunately. So we don't have a BI-RADS yet in children, but I think it's something that if I have a fellow maybe this year or in the future who's interested in that, we're maybe creating that soon.
Yeah. Yeah, I think that's interesting because, there's such an independent set of kind of norms and standards. And I guess I just hadn't ever thought, because again, I never saw breast ultrasound in peds to think, is that an avenue that we've gone down? But it's reassuring to know that, there are people thinking about it. It's also even more reassuring to know that it's not a heavy necessity right now. But when we talk about the radiation standards, is there a way that you screen, we talk about adolescents that have radiation, but we're going all the way down to wee little ones, unfortunately, these days. Is there a way that you screen? Is it the same for those kiddos throughout their development if they had radiation really young?
Are you talking about for breast lesions or just in general?
Just in general.
No, I don't think there's any screening protocols in like babies.
Yeah.
But the oncologists will know what to look for later in life, right? So we don't have like specific things, but if children have hemihypertrophy or Beckwith-Wiedemann, right? Certain genetic disorders that predispose to renal tumors, pancreatoblastoma, hepatoblastoma, we do screening ultrasounds routinely for those kids. Right. So a lot of genetic disorders, right? Leaf-Ramoni, they might get a whole body MRI. So we have a huge genetic component, obviously, at Texas Children's. So we know that there's certain disorders and these kids can develop malignancies later in life. So yes, we do screen.
So we've talked a lot about the evolution of ultrasound. Again, I think for me, really bowel, every time you bring your bowel presentation in, I'm blown away. Just at what we can do. There's so much to say. I don't know how many times a lecture I say, well, 5 years ago, we didn't see this, but now we do. Or, when we talk fallopian tubes and GYN, we used to say, if you see them, they're abnormal. Not true. So I think the standards have changed. I think the other big one for me is lumps and bumps. and how much we know about lumps and bumps. Um,
And how much we're screening for
yeah,
lumps. I
yeah,
think now sometimes I gotta admit, maybe I do get a little bit too annoyed because I don't think that every single tiny pimple bump has to be screened, right? But it's made us really good. And we all have lectures on lumps and bumps, and you've probably seen mine. And those are the ones that, again, are my favorite to go in and to speak to the parents, because lumps and bumps, you start off just like a breast tumor or breast lesions. I say the majority in pediatrics are benign, right? And our point, and the point of me is I'm not a pathologist. I can't always give you the histopathology, but I can tell you, is this cystic or solid, vascular or not? Do we need further follow-up intervention biopsy, or can we just leave this and like move on with our day and everything is going to be fine? So
yeah,
I think that's really important to give, again, peace of mind to parents. Do we have to do a CT scan for a little supraclavicular node? Probably not. So we have a very huge, obviously, lymphoma population, but LCH, right? Langerhans cell histiocytosis. So every Thursday, me and my 3 other colleagues, we do LCH lymphoma conference. That was predominantly CT and MRs. And in the last 2 years, it's becoming ultrasound head and neck, ultrasound head and neck. And I've noticed that that group is moving away from doing CTs of the neck to now just doing ultrasound with that palpable abnormality, which is great because we can see such beautiful lymph node architecture now with our high resolution probes, right? These
yeah,
little hockey sticks. So the resolution is so beautiful that I actually spend time on my lumps and bumps lecture giving examples of completely normal lymph node morphology and then what happens when it transforms to a malignancy, right? It's the malignant ones that start losing their beautiful reniform shape. They don't have that nice fatty hilum. They become, taller than wide. They become hypervascular. And these are the ones that, we need histology and we need to do an FNA, and we're not going to sit on this. For
yeah.
example, I had this left supraclav node that sat for 3 months because everyone thought it was mono. I bet you back in the day, if we just did a quick ultrasound, we would have thought, you know what, we didn't waste 3 months, and by then it had spread to the axilla
Yeah,
and was upstage to it too. So we probably could have just done an excisional biopsy really early on. So I think lumps and bumps are great for differentiating normal and abnormal. And if it's abnormal, of course, you can do an ultrasound guided biopsy, or you go on to get CTMR if further imaging is needed. The second place I think it's really helpful is we do so much at night. We're just, looking for abscesses, right? Not just in the head and neck, pilonidal cysts or, cysts anywhere in the body, or infected abscesses, I should say. And that, in the ER, it's so fast. So you get the answer fast.
yeah,
No radiation. It's fairly cheap. It's portable. And I mean, the biggest thing I can't stress enough is just no radiation to the kids. There's just so many side effects that occur later in life.
yeah.
And I love ultrasound for that. So I'm actually leaving in 20 days. I'm going overseas again to the main kind of MD Anderson of Pakistan. It's called Shaukat, and I train their sonographers and their trainees. And most of my lectures are on ultrasound, and they love that. So this is my 3rd time going, and in a third world or developing country, imagine ultrasound is a huge benefit for them. And mostly it's not the sonographers doing it there.
No.
There it's the residents and it's the doctors that they're doing the 24/7 ultrasounds themselves. So here I think we're a little spoiled, and I do feel that maybe our trainees are not as good as maybe some who come from abroad, because they're doing the majority of the diagnosing with ultrasound as opposed to the fancy CTs, MRs, which they don't have maybe access to. It could be much more expensive for the general public. And as much as I try to do more ultrasound scanning weeks for my fellows, I think, they're just phenomenal overseas because of they do so much.
Yeah,
It's easy. So yeah, I'll be going there in a few weeks just to train and to give maybe the bowel ultrasound and things like that, those lectures, which they may not be doing.
yeah. You need a sonographer to go with you.
Right. Yeah. Anytime I will, I'll ask them.
Don't tell my husband. Don't tell my husband.
Seen sonographers there. I literally just trained the doctors. I've never seen their techs, which actually I'm going to go and ask them this time. Like, can you introduce me to some? Because I'd be interested. It's more trainees, I should say. Yeah.
Yeah, it's a lot of physician led. That's what, I haven't had the privilege to go overseas, but when we do talk to our counterparts of, some of our other regions, there is that variance. And even down in Latin it's sonographers are a very first world US, US Canadian And even in Europe, it's a lot
Europe.
of physicians that are doing the exams.
Yeah.
So, I think some of that is amazing. It helps our diagnosis. It, streamlines the communication and things like that. But I would like to keep my job, so we'll keep stenographers here in the US. But I just think it's amazing the application. And when
Yeah.
we talk about ultrasound in third world countries, you don't have the privilege of having an MRI system. You don't have the privilege. We talk about our volumes here, and then you look at the volumes and, the Eastern Asian regions and things like that. We think 20 patients a day for a sonographer is a lot, and they're seeing 40, 50, 60
Maybe more.
more,
Populations of like 1 billion. So what they're
yeah,
seeing is huge in their throughput and this and that. And for them, they may not have the fanciest, like even ultrasound technology, like you're saying. Do you think they have all the contrast enhanced ultrasound? And do you think they can take their time deciding VCG or contrast enhanced ultrasound, or even liver lesions or kidney lesions, right? Like now we're just kind of playing around in a sense and saving radiation, but they don't have that opportunity.
right.
Elastography, and look how easy it is like now for AI templates, right? Everything just gets loaded in. So I think we're very, very lucky here. We're very, I guess, spoiled in a way, and I do feel very thankful and grateful. But I do think that maybe I didn't get the training as a resident or a fellow in scanning. I don't think I'm as good of a scanner as some of my counterparts over there, and I depend on you guys so much. So I would really like to do a better job in training, and that starts at the medical student level. And discussions are to have ultrasound as a core competency now,
Yeah.
because POCUS is getting more popular. A lot of folks are going into ER and doing a lot of fellowships in ultrasound from the ER, and people are worried about AI. And I don't think that I always say AI is not going to take over radiology. I think you're always going to need us, especially in pediatric ultrasound and pediatric radiology, where it's a more hands-on approach. I don't think a robot can be doing everything, but I do think AI has greatly assisted us.
Mhm.
And I think it will in the future. I think our diagnostic accuracy will be better. I think there'll be more uniformity among all of the different institutions. I think quality QC issues will be resolved and could be improved by AI. So I think there's a lot of hope. But when people come to me and say, I don't want to do radiology because I'm not going to have a job in 10 years, I don't think that's entirely true. I think
No.
it's going to be able to diagnose and help and be there for for kids and for patients. I don't think they want to speak to a computer when they're going
No,
to.
and there's an art too of, uh, again, being medical, I'm spoiled. But when I seek out doctors, I don't, yes, I want a well-educated physician, but I want a physician who's practiced. I think there's an art to practicing medicine. And AI isn't that. It's decision support, and it can tell you what the data and the files and those things say, but it isn't practice. It isn't patient care. It isn't in my experience, those kind of things. And so I say the same thing. It's here to help us.
Yeah,
It's never going to do an ultrasound all by itself. And the regions we're targeting for it to do that are the third world countries that are, seeing, they have hundreds of patients line up every day just for the chance to see a doctor. Can we help in those aspects? We're tucked in tight and pretty here in the North American region, but can we help those other regions? Can we, even help our rural areas? The sonographer that's never seen a ped before, do we have AI that can help her look for an appy to know send this kiddo home or not? Again, it's nothing against that sonographer, but it comes down to experience, and that's where I really see AI assisting. But I agree, I don't see it taking over.
I agree. And I think just like, when you have so many, say on a pelvic ultrasound, you have so many measurements
Hmm.
to dictate. There's more chance that I'm going to say 60 instead of 6.0. It's just those little diagnostic errors that if you're doing hundreds in a day, but if AI can just import that in.
Yeah.
And we're already using it every day, right? We do bone ages using AI, our scoliosis radiographs, hopefully they're going to be doing the measurements. So we are doing a lot of AI kind of novel techniques, and starting off at Texas Children's, which is great. We have like whole division chief of AI, and she's done some really, really wonderful work. So I do agree with you. It's going to assist us. I think it can improve diagnostic accuracy and help with quality and kind of QC issues, but I don't think it's going to take over. It's great. It's helpful for a lot of things, but I think you're always going to need a sonographer. You're always going to need us. We're going to need to have discussions like this. The biggest thing is it's that emotional support to a parent or a child. It's just not going to provide that.
No. And that's such a delicate and necessary balance in your everyday, So we're winding down on the last few minutes. Any last kind of, what is your life's dream for pediatric ultrasound?
That's a great question.
Loaded question.
That's a good question. I think I need to do a better job of getting my trainees trained in ultrasound more. I don't want them so dependent on CTMR that they lose the love of ultrasound, or they lose this like, oh, it's so simple, it's just kind of the lower modality, you know what I mean? Like X-ray and ultrasound is not important, and we just want the fancy 3D and 4D stuff, which you can have 3D and 4D ultrasound. So I think that's really important, as we need to kind of bring it back into the education realm, especially in that is targeting medical students and getting them interested in not only ultrasound, but in pediatric ultrasound. And as you know, there's a huge shortage of pediatric radiologists. So I think targeting them young, targeting them early, getting them excited. We take them into cases, we show them contrast enhanced ultrasound, which I think is great. We started contrast enhanced ultrasound maybe before COVID, then COVID shut it all down. We've already done 70 or 80 cases at Texas Children's. I don't think it's something that the clinicians are just going to do, but at least we have that option to give them now, and I want to grow that service a little bit more. I would like to do more elastography with breast and thyroid lesions, so I think that's going to be something in the future I'm going to be looking at. And like I said, I want to like incorporate ultrasound into more multi-modality approaches, and maybe fusing it with a PET or fusing with a CT or ultrasound, like in the future, and see what multi-modality approach, both in diagnosing, biopsying, and then treating tumors, cancers, things like that. So I think there's a huge role. And then again, helping our rural folks, helping those internationally. I have a big passion for helping those overseas. And that's why I'm going back to my third or fourth time to that one as well. I think it's a lot of fun to give them the knowledge what we have. And it's really, really special. You do it for free, you do it from the love of your heart, and they really enjoyed it. And they're just so, so grateful.
I love that.
Yeah.
Well, thank you so much for your time. Thank you for joining us. I always love our conversations. Super jealous. Travel safe. And thank you so much.
I promise next time I need a sonographer, they let me take somebody, I will contact you. But again, thank you always for inviting me and for thinking of me. I love this stuff, and anything to help anytime. Thank you so much, Beth.
Thank you.